Esse? Tá dando para ver ali? No, it's working?
Yes, working.
Okay. So, bom dia a todos. Good morning, Professor André Wolff. Professor Wolff, ele é anestesiologista, chefe do Departamento de Anestesia da Universidade de Groningen, na Holanda, e está aqui no Brasil conosco, o Dr. Hazen e eu, para uma disciplina de dor, uma pós-graduação em dor. E hoje é a primeira aula que ele vai falar para nós sobre dor aguda pós-operatória. Professor Wolff, we are going to talk about acute post-operative pain. And we are very, very happy to have you here. So you can talk whenever you want.
I can start right away. Thank you very much. First of all, it's an honor for me to be here, I will put it this way, and to give this lecture about pain medicine, and specifically acute pain medicine and post-operative pain medicine. And so it's also an honor to just to see your university, your medical center, and to meet you people, and also in the case of collaboration. So I will start. And well, we have also the Unical Medical Center. This is the entrance, but there's also in another, well, maybe 8 kilometers from this center, we have another center where we have the daily center for the pain medicine and with ambulance care, actually. And we also do interventions there, but the interventions that need an operating theater that are performed in the central center in the University of the Medical Center of Groningen. If I talk too fast, then please tell me. Then it's difficult to know. So this is me, and yeah, we have this the pain center of the University Medical Center, and I will have a talk today about, as asked also, the neurobiology and pain mechanisms. If you are talking about acute pain, you actually also need to know the basic mechanism to better identify the pain after surgery, because it's not only nociceptive pain in many cases. And it helps if you can identify, because you probably need another treatment. That's why. Okay? First of all, well, this is a map. You know your own country, Brazil. And here you see the small, I can show it here. Does it work? Well, but a little bit up and left of this arrow, there is the Netherlands. And you see, this is quite a distance from Sao Paulo to Groningen in the Netherlands. This is in the middle of Europe, actually. And so this is the, yeah, but
not here.
Oh, there. Okay, yeah, in the middle, yeah. So there's, you see that point here? This is the small one here. That's the Netherlands. It's a very small country. We have 18 million people only, and you see it's even much smaller than Portugal. And so this is the Netherlands, and Amsterdam is the capital city. And you see also here, this is Groningen. It's the department of the hospital and the department where I work, Groningen. And it's one of the largest hospitals of the Netherlands, together with Amsterdam. And we are probably known for many people with the wood and yeah, you know, and the tulips, yeah. And there's also football. Also in Netherlands, football is also important, like in Brazil. And we have the mills, and we have a lot of water. It's a water country. So water sports is very important for people. and also in ice one can skate. So in winter we have a lot of fractures because of skating and people falling down, and leg fractures and arm fractures. So this is the hospital, the university hospital. It's about more than 1 kilometer of all buildings. It's only hospital and the medical center because all the faculties of the university are outside the city. Okay, so this is in the middle of the center of Groningen. It's very special because this is the only city in the Netherlands that has a university medical center in the center of the city. So for a long time I just walked for 2 minutes and could go to enter my hospital. That's very... Oh, okay, thank you. This is working also. Now, you see skating, national sport also. We had the Olympics and we had a lot of medals, gold and silver and bronze medals. And you see also football, and maybe you recognize this is Memphis, it's the Corinthians. It's, I think, not far from here, isn't it? Yeah. He's also playing in the national team. So, this is the class that I'm allowed to give a lecture. Welcome, everybody. And so, I made an agenda. And what is pain? Because it has many manifestations, pain, and it's good if you can understand this and can identify. We focus on prevalence and on the characteristics of post-operative pain. And I will learn you a method to identify the types of pain, the types of mechanisms, because it's important in daily practice if you have eye for this. And I will finish with a summary. So, there are quite a lot of people. Is my phone that is disturbing? I'm so sorry. Yeah. So lucky us, there are some people in the room. Yeah. And so I can ask a question. Who does think that pain is a symptom? Maybe you raise your hand if you think pain is a symptom. Nobody? Yeah. You are allowed to just, if you really think so, then you can raise your arm. Or do you think that pain is a disease? Yeah? But still many arms are down. Yeah? This or both? Okay. Well, I have 3 key images. If you can remember these key images, actually you have some guideline for yourself to use in pain medicine. The first one is the definition of the International Association for the Study of Pain. And it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. It was revised in 2019 because resembling it was very an important part of the definition because you can't see pain. And if you're old, or if you're a child, or even we will discuss this, if it's not demonstrable what the problem is, you can have pain. If the patient says, I am in pain, then the patient is in pain. It's very important. The second one is for pain, and the longer the pain exists, the more dimensions will be part of the problem. And the impact will be in various domains. We have, of course, the physical domain. After surgery, there's at least a physical domain. Because of a tumor, you treat the surgery wounds and the pain itself. There can be comorbid disease that also can be part of the pain or influence the pain. Then we have a psychological part, because if something is happening to you as a patient, it might have impact on your mind, your mental status. So anxiety and fear from suffering. If pain, some patients are in depression, you have a bad mood, or after surgery also, or already in a bad mood when they have surgery and starting to get pain. It has influence. And then there is also the social part, because if you have pain and you have surgery, you can't work, you have to recover, and many patients of them will still have pain afterwards, not only a few days, but maybe for months or even for years. So this is also the case which can happen after surgery. And it has impact on your job. You're not functioning quite well, and you make worries about yourself, about your family, and about your work, etc., and your social contacts, and maybe you're going to lose them, and you're going to experience a lot of limitations in your life. And then, of course, when there is long time persistent pain, and you experience limitations, then it's going to change your life. It's not as it was before, and you have to change your mind. What are your new goals? Because sometimes you cannot do anything that you did in the past. Your life has changed, and one important part of the process is that people have to accept this, and they have to be guided to this. It's very difficult to change, because people don't want to change, actually. So, then the third slide that I like you to remember is that pain medicine is medicine. And we have a medical cycle. So there's a patient entering your room, or you are at the bed of the patient, and the patient has a complaint. So you use a history, you take a history, you do a body examination, and if important or relevant, you do also additional examinations like blood, lab tests, or an X-ray, or MRI, or whatever, you know. So you want to know what is the supposed substrate that is the problem that might be the basics of the pain. Then you might find pathology, but it also might be the case that you don't find any pathology, although despite there is pain. Then we have three basic diagnoses, basic mechanisms. There's nociception. We will discuss this. It's pain because of damage or disease of tissue in the body. There's neuropathy because there's damage or disease of your neurological system, a nerve or more extended than only one nerve. And it can be nociplastic, and this is pain because all the signals that are entering the nervous system are processed in a different way. And this can make you happen that you are persistent in pain. And when doctors don't know this, they're always looking with the patient, via an MRI or CT or whatever, we must find something, and you're not going to find anything, but still there is pain. So, and there is central sensation. It's not a pain mechanism, but this is a huge collection of pain mechanisms, neurobiological, neurophysiological, inflammatory, etc., that influence your central nervous system, and that's why also the pain can persist. But we will discuss this later, yeah? So why do we need to treat acute pain? Because, yeah, you have pain, and you say, maybe after 3 days there's less pain. Why should I treat it? Well, it's because in many patients the pain will be chronic. And it's about 20 to 30% worldwide that patients suffer from chronic pain. And there are many publications about this that you can find in literature. And it leads to a lot of suffering and an economical burden and social burden of in society. So what preferences can we find? So you can see the numbers here. It's in Europe 1 to 5, 20 to 30%. It depends also on the type of the study, the type of the surveys. USA 30%, and Netherlands 1 to 4. And this was for 2 years ago that we did the last survey in the Netherlands. And we have only 80 million people, so at least 3-4 million of the people suffer from pain, more or less. Not everybody as severe as all, but maybe it's coming back for a period, and then it goes, and it comes back. Oh. Maybe, oh. It's like some problems, they resolve itself, okay? I found some publication from Brazil. And this is the knowledge of anesthesiologists and surgeons in the northeastern part of Brazil. What do they know about, how do they know about definition and prevention of pain? Do you know? So, I did a summary of the most important information of this publication. So there were 22 questions just to check what do they know, and also about their training. So it seemed to be that most did not have a special training or expertise in pain, while it's one of the most frequent symptoms in all medicine and in life. Most had only, if they had pain education, it was undergraduate, not later. So you're lucky that we are talking about this now. Thank you for this invitation. Very good. And surgeon gave more incorrect answers about acute and chronic pain than anesthesiologists. Well, lucky anesthesiologists, but there's some room for improvement for the surgeons, okay? And there were hardly any recommendations about antidepressant medication in acute pain or anti-epileptic. They don't know how to use it. Then also nice to know that anesthesiologists believe in opioids, but it has also there are also dark sides of opioids. We'll discuss this also later. And if pain is chronic, then there are more surgeons and anesthesiologists, and more anesthesiologists than surgeons, that believe in the effectivity of anti-epileptic drugs in chronic pain. So, then there's another publication that was relevant for this presentation, and that's the prevalence of chronic pain in Brazil. I've showed you the numbers of Europe and USA and the Netherlands, but there's also a systematic review and meta-analysis of Brazil. There were 15 studies included. The prevalence had a variance between 23 and 41%, so it's not really different from worldwide. And most patients had moderate to intense pain. If you have a numeric rating scale of pain, 0 is no pain, and 10 is, well, you can't stand it anymore. You can't not live with this pain. Then it's more than it's more than 5 or more, you know. And the patients had a higher risk if they were female, they were older, had a lower education, had an excessive use of alcohol or smoking, cigarettes, central obesity, and also if there was a mood disorder and sitting a lot. They are all risk factors. It's not a mechanism, but they are risk factors, okay? And patients, when they have this post-operative chronic pain, then they have a lot of limitations like immobility, depression of the immune status of the system, disturbed sleep because they have pain and they are a lot of time awake and they are tired in daytime. They have reduced appetite, drug dependency like opioids and all the adverse events of it, and also dependent on other people that they need the help of these people. It can be family or other persons, and they experience limitations in work, which can be a problem if it takes too long time. And they lose their contacts. Many of them suffer from fear, anxiety, so they have a bad mood, and even a shorter life. Patients with chronic pain, most of them have these problems, and the mean lifetime is shorter than patients without and people without pain. Well, after surgery, that's an important thing because there's a planned scheduled trauma. We can know when the trauma is going to be there. So actually we can do something with it. We can maybe prevent. If we understand the mechanisms, maybe we can do something before and also while after surgery and in the post-operative episode. So worldwide, we do about 300 surgeries in 8 billion people. You see the ratios here. And you see here Europe, opened for USA the most surgeries per individual. I was recently also in Armenia. It's in the western part of Asia, and they have only 3 million people, and they do only 150,000 surgeries. So there's a huge difference in variances between countries. And in Brazil, this is the numbers that I found. In great Sao Paulo, Brazil, there's 213 million people. And in Great Sao Paulo, because I know the city is not the same as Great Sao Paulo, there are 23 million people living here, and so the ratio is almost 0.07. So there's huge variance, and also a difference with USA and the Netherlands. And it probably also has to do with welfare and the availability of facilities. Chronic post-surgical pain is pain developing or increasing in intensity after a surgical procedure in the area of surgery, persisting beyond the healing process at least 3 months. Then it's chronic, by definition, and not better explained by another cause such as infection, malignancy, or another pre-existing pain condition. So it's there purely because of the surgery. And how severe is this pain, and what is the prevalence of pain after surgery? This is a meta-analysis and a systematic review. And this is, Esther Bogatsky is also a professor in anesthesiology and pain medicine in Münster. We have a collaboration with Münster, it's Germany. And she had this publication, it's this systematic review. They started with almost 9,000 publications, and there were only 27 included because of the quality criteria. And then can we see here that 1 day after surgery, then there is 31% of the patients in pain. 2 weeks, 1 to 2 weeks after discharge, it's 44%. It's raising, it's increasing. Maybe you did not expect, but it's increasing. They are at home, those people, with pain. And this is ambulatory surgery, then 29%. It's like the smaller surgery. And when patients are still in the hospital, then it's only almost 60%. These are really numbers to be conscious about, because these people, maybe we can help them. So I show this to be aware of the problem. And there are, of course, also differences between kinds of surgery. After amputation, it's almost, 80%. Not maybe continuously, but by episodes, and very intense, and also resistant to pain therapy. Sternotomy and abdominal and thoracic surgery, also high numbers. You can see it here, like sternotomy and cholecystectomy, between 3 and 50%. But also breast surgery, high numbers. You see? And coming back to the risk factors, we also, for the chronic pain, we mentioned them. But if there is already pain, or they already use opioids, there's a higher risk to become chronic, or to increase the pain after surgery. Psychological vulnerability, female, we also saw anxiety, if it's there or later. Workers' compensation, how does this work? Maybe there's another reason that also influences the pain, because the life has been changing of this patient, and workers' compensation might have influence on this patient and behavior, and also the needs of this patient. The type of surgery and also damaging the nerves is an important factor in post-operative pain. If we can prevent neuropathy, like the techniques that we have for inguinal surgery, it really reduces the prevalence of pain. And there are also post-operative factors like the pain itself, and raising the pain and also making it chronic. Neurotoxic chemotherapy, the mood is playing a role. Neuroticism is an old word actually, but if there's a psychosocial vulnerability. So there are a lot of factors that we maybe can identify and we can use to prevent pain and to treat. So this is these are risk factors, but risk factor is not the same as a mechanism. There are a lot of studies now also basic for biomarkers, inflammatory biomarkers, psychosocial biomarkers. We can test the somatosensory nervous system, how to process all the signals that are coming into the nervous system. So we recently also this is also studies with people that we collaborate with, and so pain intensity and high pain within 30 days after surgery is really a risk factor, and bone surgery is also a risk factor, and there are many inflammatory factors that are recognized now, but I didn't put it in this presentation. So surgery, you think, well, we put a knife in the patient and we get out the problem and we close the patient. But what happens in the surgical patient that also gets anesthesia? Well, it's trauma. There maybe was also a trauma before, but also a new trauma because of surgery. There's nociception because nerve endings are excited by the stimuli and by the damage. That might give nervous damage in the nervous system. It might also change the processing of the stimuli in the nervous system, peripheral or central. It might be synthesized because of this, because your nervous system is the only one connected to all you can do and all you can experience. There is a neurohumoral response. So all the axis of the hypothalamus, pituitary adrenal axis is changing. There's inflammation. And you also need inflammation to restore the tissue, but there is inflammation. There's also a change in coagulation. There is a suppression of the immune system. The first days there's catabolism and afterwards back to anabolism, and there might be insufficient wound healing also maybe being part of the pain. There's sympathetic activation of the autonomous nervous system, and there's also maybe if they have already in risk cardiac consequences, gastrointestinal, also because of the medication and by surgery itself, and because of anesthesia, and also respiration, specifically also when there's abdominal or thoracic surgery, is also depressed, the respiration function. So there is happening a lot in the patients that we give surgery and anesthesia. Just a few pictures that show you the relationship between the pituitary and the hypothalamus, and the fact that the patient have pain because of the trauma, nociception and inflammation, and that's because of the damage of the tissue. There are a lot of cytokines and stuff that is going into the body or into the area of the surgery that is also increasing the pain. Then there is fasting, anxiety, stress. So, and I told this also, there's many, this is just a simplified scheme. Here's another. And it's also for the kidney, we are retaining water, and so it's also something that has impact on the cardiorespiratory function. And of course, the cortisones and epinephrine from the adrenal function is also changing in these patients. This is an oversight of a lot of hormonal changes that actually take place in our patients. And it's just to see, because we're going not to discuss all of them, but you see there's a lot of hormones that are all changing and can have impact on a variety of functions in the patient. It was not ready yet, so this is the second slide with other hormonal effects. And also on the immune system, you can see here interleukins, macrophages, endothelial cells, etc., T cells, tumor cells, killer cells, etc. They all might change in function. So I have a case for you. Miss, I do have pain. And she's 39 years old, she's healthy, but she has fallen and pain in her leg. She has a femur fracture. So she needs surgery and gets an osteocentesis. And she suffers from post-operative sharp continuous pain in her leg. And it's in the upper part of the leg, around the wound of the surgery. And when she's resting, just lying, then she has a numeric rating scale pain score of 5 at the scale of 0 to 10, and 8 while she is moving. So who think this is a neuropathic pain? Maybe you can raise your hand if you think it's neuropathic. See no arms raising. Do we think it's nociceptive? Yeah, most arms are now raising. So now we are coming to the pain physiology and mechanisms. Nociceptive pain is pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of nociceptors, the nerve endings that can receive the signals. This is a simplified scheme. So there is at the nerve endings of nociceptors like chemo stimulation, acid, or capsaicin. You know capsaicin, the peppers, you know. It might be mechanical, by cutting or by hitting, by example, or trauma. And and temperature is also, high temperature, very low temperature is also stimulating the nociceptors and might give pain. You see here, for temperature, it's usually less than 15 degrees Celsius or more than 40 degrees of Celsius, then you will experience pain probably. So pressure, mechanical, temperature, and damaging by chemicals are the most important game changers for pain. So there's a trauma, and here you see enlarged the trauma. And this is also simplified, but there's a lot happening in the trauma area. And because of this, over the axon, the signal is transported to the myelin and goes up to the brain. And only, this is very important, when the patient is conscious of the individual is conscious, then it's pain. So nociception is not the same as pain. You can have a lot of nociceptive processes in your body and not be aware, not having pain. Although there might be damage, okay? There is also peripheral sensitization because of the chemicals and the cytokines that come out of the damaged cells, go into the peripheral side of the wound and are going to lower the thresholds of the nociceptors in the environment. So we call this peripheral sensitization. And it looks like this. There's the trauma. It's with the primary hyperalgesia because it's a wound. And then the surrounding tissue is going to be sensitive, more sensitive. We call it secondary hyperalgesia, also for gnostic or for the vital sensory function. And so the gnostic is for the A beta. You know the A beta nerves? So the thick nerves, myelinated. And we have the A delta and the C nerves that are, the A delta are myelated, but the C nerves are not myelated and have a slower transduction and the transport of the signals over the nerves, okay? So peripheral sensitization, I told you about it, but it can go also to the wide dynamic range neurons. It's like roundabout neurons in the central nervous system, and that's important. We come back to this. So the peripheral sensitization can lead to central effects, by example, via the wide dynamic range neurons. So, simplified, nociceptive pain pathways, there's damage and transduction because of activation of the nociceptors. Then it goes to the myelin, and there's transmission upwards to the brain. It can be modulated. We'll discuss this also. It can be modulated by a lot of mechanisms that can increase the pain or reduce the pain. And pain perception, for pain perception we need that you are conscious about pain, otherwise there is no pain. When you see the myelin, then the dorsal part, there we have also the introduction, the entrance of the A delta C vessels and the A beta vessels. And more centrally in the myelin there are the white neurons, and they are transporting the signals to other nerve cells so that they can extend via the nervous system. And we have 5 identified pathways. It's not only the spinothalamic pathway, the most known at the lateral side of the myelin, but there are other pathways that also influence in the ascending pathway for pain. It's spinal-reticular, that's formatio reticularis, spinal mesencephalic, with the cervicothalamic pathway and the spinal hypothalamic pathway. You don't have to remember all of them, but know that there are more pathways than only spinothalamic. So if you cut the spinothalamic away, still the patient can be in pain. There's a lot happening for descending inhibition, and I will just discuss some of them. Descending pathways, and because it can be presynaptic, it can be postsynaptic. There are a lot of catecholamines like serotonin or noradrenaline or epinephrine that can influence the thresholds of the cells in the central nervous system and can inhibit the pain. And you can also use these mechanisms for pain treatment, because it's actually the same mechanism that the body has evolved itself in nature. We can use it also by external medicine, by example. Like antidepressants, because catecholamines can inhibit, so you can raise levels of catecholamines in the brain and in blood levels. Or the opioids, or glutamate with the NMDA. You know the NMDA receptors? Via glutamate. We can, by example, by ketamine or by methadone, we can increase levels. So this is a schematic picture with the ascending pathways in black. And you see there are collateral pathways. And the longer pain exists, the more centers will be involved in pain. This is very important, because this is why it's going to be an extended problem, because more brain is going to be involved in the longer period when pain is persistent. In 2090, the International Association for the Study of Pain has identified these secondary pain syndromes because of trauma or disease, and we have they are clustered like chronic pain, post-surgical pain, and post-traumatic pain, neuropathic pain, head pain, and orofacial pain, visceral pain, and chronic secondary musculoskeletal pain. This is a very large group. The back pain, neck pain, etc. Oh, sometimes it needs a pause, I think. Yeah. Okay, but it's coming back, so no problem. So these are the characteristics of nociceptive pain. You can find the cause via a history and by physical examination. So there's trauma, or inflammation, or cancer, or surgery and post-surgery, and you can find where the problem is. And it's good localized. You know where it is. Nociceptive pain, and very important. Nociceptive pain usually responds well to classical analgesics like opioids, paracetamol, and NSAIDs. Okay. The assessment by taking history, examination, and maybe additional examination by CT, blood drawing, etc. And the therapy is causal, because the problem has to be solved itself. But the pain can be symptomatic in this nociceptive pain, unless there's a persisting problem, and therefore the pain can persist. And pain therapy is symptomatic, that's by analgesics, and physical therapy and rehabilitation. This is most important for the nociceptive pain. Well, we go back to Miss I Do Have Pain. It's a few weeks after surgery, and she complains about stabbing pain in the frontal part of the upper leg, in attacks now, attacks-wise, 20 minutes, around 20 minutes. She has a pain intensity of 8 if there's an attack, but sometimes there's no pain. It's gone. And when you do physical examination, you find that there's no feeling anymore at this upper leg. But touching is painful at the same time. What do you think? Is it nociplastic pain or is it neuropathic pain? Raise your hand if you think it's nociplastic. No hands? Raise your hand if you think it's neuropathic. Yeah, many hands. Okay. So neuropathic pain is pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. It's an international association for the study of pain definition. And so nociceptive pain, there are many causes, and we also talk about the traumatic and the post-surgery neuropathic pain. And it can be stimulus dependent and stimulus non-dependent. So there can be spontaneous pain without touching or without moving, whatever. And there are various kinds of damage to the nerve. There might be neuropraxis, myelin damage. It is quite good prognosis because it can be restored. There's axonophthalmia, and ophthalmesis, that's the disruption of the axon, but the sheath is intact. It can regenerate, and there can be neurotmesis, there's complete damage, and this can be irreversible. And after 3 to 6 months, you really know that it will not recover anymore. You see here an example of a damaged or a diseased nerve. It can be myelin, it can be in the axon, it can be in the nerve body itself or in the dendrites. And this is the difference with the healthy nerve cell. So neuropathic pain is quite fast presenting after surgery. And 7 to 10% in the general population. But after surgery, it's about, the literature says 3%. And it can be neurologic, but also other causes causing the damage of the disease of the nerves. And it can cause the chronic systems, chronic problems. The characteristics is that the changes in sensory function, pain or dysesthesia or anesthesia or hypoesthesia or allodynia, you know these terms? Then they have to follow the innervation pattern of the nerves, because if it's not, it's probably not a nervous problem. It's very important that there is connection with the innervation area. There can be positive and negative symptoms. Positive is like pain, allodynia, dysesthesia, and it can also be negative hypoesthesia or anesthesia. And these pain patients respond quite bad to the usual treatment for nociceptive pain. Only about 1/3 of opioid treatment. And like the TCA, tricyclic medicines, it's about 1 to 4, pregabalin 1 to 7, numbers to treat. I am talking about numbers to treat, okay? So if the patient is not responding well, you have to think, why is this? It might be neuropathic. This is really also the reason why I tell this. So my question to you is, are positive symptoms and signs typical for neuropathic pain? So dysesthesia, attacks, allodynia, pain itself. What do you think? Is typical for neuropathic pain? Please raise your hand. I see them, yeah, many of you, okay. We're going to discuss this. It may also be present in nociceptive pain, but maybe more frequently present in neuropathic pain. So it's not 100% that it's always neuropathic pain. Yes, remember this. We did also studies to demonstrate this. And when we are talking about assessment of neuropathic pain, then then we try to know if in history if there was a trauma or surgery or metabolic dysfunction. There are also many metabolic diseases that can cause a neuropathy. And we have the neurological tests, the nerve conduction tests, so we can make an objectivation of the function of the nerves. And well, therapy is actually also restoration of the nerve function itself, but also symptomatic because of the pain, and maybe also of the motor functions, the dysfunction that can also be there. And usually patients better react or respond to anti-neuropathic medication like the anti-epileptic medication and antidepressant medications. Okay? Well, there's still Miss I do have pain. She complains about stabbing and burning pain at the upper part of the leg, and it spreads out to the lower leg, yes, from downwards, and to the dorsal part of the leg and the back. And pain intensity is numeric rating scale 4, and when she has attacks, a numeric rating scale of 8 on the scale from 0 to 10. Now she is also complaining about many tender points over her body. It's generalized over her body, not only in the leg or the back. She also complains about less concentration. The focus is less. She's tired. There's fatigue, less energy. So working is not anymore possible. She has to care for her children. It's difficult. And she is getting depressed after all because things are changing. She has no influence. Maybe she thinks she has no influence. And also sleep is poor. So in the day she's also, because of this, tired. What kind of pain do we have? Please raise your hand if you think is still nociceptive. No hands. Do you think it's nociplastic? Yeah, more hands. Okay. And maybe there's a gray area between nociplastic and neuropathic pain. Maybe. So, when I did my training as in medicine faculty, I learned that the neurological system, once it was there, would not change. Now, I started my education in 1978, some years ago. And now I know in my career the most important organ and the most frequently changes is the nervous system. It's not the outer side of the nervous system, it's the inside of the nervous system. Central nervous system, brains and peripheral nervous system. It can really change, and it's logical. We're not surprised because otherwise we could not learn. We couldn't learn new patterns. This is so, but it can be good patterns and it can be bad patterns. This is also important to know. Now it's altered nociceptive function, and we call it. This is the third mechanistic descriptor. Is nociplastic pain, and it's also important that in these patients you cannot demonstrate a physical or somatic or organic problem. They are in pain, but you cannot. If they want, give me a new MRI, doctor, and the doctor says, yeah, of course, but you experience pain in your stomach. There must be a problem there, but the problem has moved to the nervous system. Nociplastic pain is pain that arises from altered nociception, despite no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors, or evidence for disease or lesion of the somatosensory system causing the pain. Okay. No damage, no disease demonstrable. And what can we see in these patients? There is primary hypalgesia, so abnormal intensity of pain to a normal stimulus. Did you know that the nociceptors change in function? And not only in function, also in the number of receptors, they can increase. The number of ion channels can increase, sodium, calcium, potassium, they increase or they decrease. It's not fixed. And we have billions of it. And they can increase. And so this can also influence the pain and influence the pain system. And so there are diseases also why the sodium channel is a genetic disease is not working, so they have many pain or even cannot experience pain at all. This is also a disease. erythromelalgia. Do you know this term? Erythromelalgia. It's like a Pakistan tribe, and many people of them have this genetic change, so they can't feel. It's deadly because the system is not working anymore. And because they are poor in these tribes, people ask them, yeah, you get money, you go to the roof and you go down. Go down, you jump down. And of course there are fractures, etc. And they don't feel any pain. Okay? Infection, secondary, etc. So this is highly riskful. This is a schematic picture of a receptor. So a receptor is not an easy thing. This is a schematic, but there are many functions in a receptor, all together making the change of the receptor function. And you see there are many changes in channels and also in parts of the receptor that can change. So I already told you there's up and down regulation of ion channels and of receptors. And I told you about the erythromelalgia, but also the people who cannot feel pain if they have this genetic change of deviation. And and sometimes very difficult to treat. Now, you can see a simplified picture of the receptor. And in addition, in these neurons, there might be central neuroinflammation. I showed you pictures about this. There's modulation in various ways in the central nervous system. And there are sexual and gender differences in experience of pain. And also via the glial and neuroimmune mechanisms. They are not all the same in men and women. So a lot of mechanisms are taking place. I told already about glutamate and the NMDA receptor. There's increased efficacy of the synaptic transmission. There is change in the factors in the dorsal root ganglion and the dorsal horn neurons. There is protein expression changing, also epigenetically. If you have a lung pain, also you see when you are a child and you have a lot of traumatic episodes in your life, anxious, or you are not seen, or there is sexual abuse or emotional abuse, your nervous system is changing with other characteristics and other protein expression. So we didn't know this all years ago. So a normal stimulus will change. This is just a graphic that a stimuli under the threshold will facilitate pain. Okay, I think you know these pictures. So we talked about nociception because the damage or disease and the pain that you can experience, and it's no more anymore present because of the damage or disease. It's because of changed function in the nervous system. You can see it, and you must be conscious about this. The central sensitization is increased responsiveness of nociceptive neurons to their normal input and or recruitment of a response to normally subthreshold inputs. So this is not exactly the same as nociplasticity, but there's a lot of mechanisms together, also spreading the pain via the neurological networks. Here, you have an example of the wide dynamic range neurons, like a boundary route. You see, a boundary route in traffic, and so it's connecting to other parts of the system. You can see it here also, neural networks and the traffic. So if you have a queue on the highway, the other side is also going to have to queue if there's a lot of traffic because people are looking to the other side. And actually, there was not a problem there. So this actually also happens in the nervous system. You know? Central sensitization has a lot of mechanisms, and some examples are demonstrated here. So it leads to secondary hyperalgesia, less inhibition of ascending stimuli. There is increase of pain itself and stimuli, but there also can be decrease of inhibition via modulation that's not working anymore. And we have tests to check this. So I told you about the increasing of the upregulation or downregulation of receptors and ion channels. So there are a lot of them. And now you see that there are the bizarre patterns, bizarre percentages, because only a quadrant. And in the past we said, this patient is crazy, because how can you ever experience only a quadrant or a hemi pain for your body? And it's because of the central nervous system. And the central nervous system can provide highways and can provide special connection to parts and also in function. And this may also the reason why it presents in a different way between people. It's not always the same in people. And they are not, there is a problem in the central nervous system. There is a problem between people, but it's really present in the central nervous system. Well, central sensation, we go further. The brain's pain stimulus, and there's also can be nociception. Yeah? You see here the nociceptor, and it goes up to various parts of the brain. And this is also a representation in a simplified way. I showed you the other picture earlier with the colors. Prefrontal cortex, anterior cingulate cortex, the thalamus, periaqueductal gray, and so there are many. And the longer the pain exists, the more centers are going to be active of these patients in these patients. And what consequence does it have? Because in the amygdala, emotions, they are the drivers for emotions are in the amygdala mainly. In the hippocampus, there's memory. So the experience play a role in the impact of pain. And so there are many centers that are going to play a role, and this is the chronic pain problem. That's not only nociception after surgery, but many patients, you saw the numbers, are going into chronic pain. That's what we have to try to prevent. We can see these parts of the brain active with the functional MRI. They do tests, and we can see brain parts that are more active than other parts, and we can make calculations that we see the difference between patients with chronic pain and non-chronic pain. And so mainly there are three areas in the nervous system. Peripheral nociception. It can also lead to primary hyperalgesia and sensitization. We have the myelin with the spinal central sensitization, and we have the brain, the forebrain, midbrain, and afterbrain. And there is also a reorganization of functions in the brain. Also, we noticed after amputation that parts of the brain are taking over function. So, if the pain exists longer, it's less a symptom and it's becoming more a disease. This is what's happening. And only in less than 10% of the patients you will find a specific problem organically, somatically. In 90% you won't find it anymore. This is an example. Who of you plays an instrument? One arm, only one? Many medical people also play an instrument, I know. Well, if you play a guitar, did you not play guitar? No. You play the guitar, you can hit, you can touch the snares, and there's a sound, you know? And I'm not talking about this beautiful sound of awful sound, but there is a sound. And you are going to touch harder than the loud, there will be more loudness, you know, of course. But now they have a microphone, and there's a system to reinforce the loudness, a magnifier, and there is also a loudness box. And the loudness is not only anymore dependent on the way you touch the snares, but also on the system, isn't it? You can turn on the button or turn down the button. And now, if you are playing and it's going into the microphone and the box is behind you, what's happening? What's happening? The sound is going directly into the microphone from the box, and not only by playing. You know, when the band is playing and then you say, "Wee," you know, and oh wow, this is also happening in the nervous system. This is what is happening. So the signals are directly produced in the system and they are received in the system. And it's continuously going in a circuit around. This is also what's happening. So maybe you understand a little bit what is happening in chronic pain and central sensitization. So, how can we assess this? Of course, history, but the relationship with the organic problem, many times you cannot find, 90% you cannot find it. But you have tests that the nervous system is changing in function. We have quantitative sensory testing. This is a test that we give a stimulus and the types of stimulus and the way, and we can quantify it, can say something about a different processing of the stimulus in the nervous system. And there are many kinds of tests that we also use in the experiments. We have surveys or questionnaires. Do you know the central sensation inventory? There's the pain incentive questionnaire. And so we can also simplify the quantisensory testing. So also in primary care, you can use it just to have an idea. Maybe there might be something like sensitization or nociceptive pain. So you don't always have to use the total battery, which you need 3 hours or something like this. Now we are talking about primary pain. This was the other part with chronic pain and post-surgical pain, by example, because there is damage because of disease or trauma or something like this. And in these patients, you are not going to find anymore the organic problem. And we see these patients because if you follow them for lifetime, then we know there is higher risk to get many of these problems. Like migraine, depression, back pain, fibromyalgia, chronic fatigue. And there are various studies actually demonstrating the same phenomenon. And there are top-down synthesizers, like abuse. It may lead to hypervigilance, that they are focused on the pain, and they are not anymore able to distract. Catastrophizing and cognitions are playing a role. And there's, of course, stress. And there are also bottom-up synthesizers, like genetics, of course, inflammation, sensitization in the system. And so both can play a role in sensitization. A cortico-releasing hormone, cortico-releasing. And it's a precursor of cortisol in your body and of endoids and the opioids. Both of them are regulated by this, okay? Corticotrope releasing factor, okay? So this is an also loose, maybe you don't know the name, it was a surgeon in the 70s of the former century. And he already said, there is nociception, but finally there's pain behavior via pain and suffering and consciousness. And so this may lead to fear and depression, etc. after you have had these noxious stimuli, but it can also be after nociplastic stimuli. So we come back to this. Now you understand why all these domains, and the longer the pain exists, are going to be involved. Yeah? So it's not only a psychological story, it's really changing your central nervous system with other proteins, etc., etc. Now, how can you recognize? How can you use this in daily practice, in your practice? Oh, yeah. So patients can have nociceptive pain and neuropathic pain and nociceptive pain. If we are treating and seeing patients with chronic pain, most of them have a mix of this. But also surgical patients already can undergo surgery, already present this. So it helps you if you can recognize this. Because patients might be sensitized. And you know that in sensitized patients and in nociplastic pain, the opioids are making it worse. It makes hyperalgesia, tolerance, and patient and doctor think you have more pain, so you need more opioids, but it's the opioids who makes the patient more sensitive and more vulnerable. So it's the wrong way. And actually we should reduce the opioids. We must analyze what is in these patients present. Is there no plastic pain? Is there neuropathic pain? Is there no septic pain? And is there also something like sensitization? So I call this peel to seal. Like an orange, yeah? You peel, and after you've peeled, you can stamp on it, and then you seal. You know what you are seeing, or you know what you're eating. So demonstrate or rule out nociceptive pain. I showed you the assessment, probably you know, because this is most known pain, nociceptive pain. Neuropathic pain, demonstrate or rule it out. I also showed you the type of assessments for neuropathic pain. And the third one, if there's no reason for nociceptive pain or no reason for neuropathic pain, there's no pain congruent with the innervation pattern, then it might be nociceptive pain. But nociceptive pain may be also very local. Who of you has sometimes a wound and still the wound is for 20 years already gone, but it's still sensitive. If you touch it, it's still sensitive. Many individuals experience this. Maybe this is a kind of nociplastic change, you know? It's low threshold stimulation. And there might be central sensitization, so it's spreading across the body. There is often something like allodynia and hyperalgesia in sensitized patients. Peel to seal. So if you do this in your patient, it can also pre-surgical, pre-anesthesia, if you assess the patient, because probably you're going to give re-anesthesia, may help, or you're going to give opioids, but they're going to react different if you're already on opioids and have chronic pain syndrome. So, time to give a summary of this all. The longer pain exists, the less it will be a symptom, the less the chance that you will find something, and the more it will be a disease, because the central nervous system, inflammation, etc., it's all changing. And in less than 10% you will find an organic problem. This is the pain medicine model. It's just medicine, like all other kinds of medicine, also pain medicine. You take a history, examination, and you try to demonstrate a pathology, and if there's not, it can be, if there's no pathology, then you have the pain diagnosis. There's no plastic, eventually with central sensitization. And you have to, then we have to label this in the biopsychosocial and eventually also a predator model, and then it's a conclusion, and then we start pain management and not before, because we don't treat a complaint, we treat a pain mechanism. This is the difference. And I showed you how to identify with peel to seal. This was, I think, that I could tell you about also post-surgical pain, chronic pain, because there's an overlap in it, but it helps if you also know the mechanisms that you can identify in these patients. I hope this helps you. Maybe questions?
Alguma pergunta, gente?
Dr. Wolf, you said that the prevalence of pain increases after 2 weeks, 1 month. It's higher than the right after the in the immediate post-operative days. Isn't that? Yeah. And do you think this is because usually we give a better analgesia during the period the patient is inpatient, and later when he's discharged, he goes with less medication, or?
Good topic. Sorry. I think this may be one of the problems, that while if we are there as anesthesiologists with the patient, we see the patient and we give analgesics, etc., and we have a local regional block like epidural or regional block, etc. But after hours or after 1 day, it doesn't work anymore. And we think after 2 or 3 days, pain should be reduced because this is natural. So we reduce medicines. And we don't really follow the patient. And you're right, probably this is one of the problems, that we are not adequate in pain treatment in this period. Yeah. So we can do something about this. But we have to follow. So there are more transition teams in the hospitals, and they actually also start before the surgery, just to assess what are the problems, is there high risk or not, and also to early identify the risk to increase pain, which is a risk factor for chronic pain, and treat in an early stage. And it might be in the biopsychosocial model. It can be from everywhere. Okay, other questions?
Congratulations and thank you for great presentation. My question is about the prehabilitation. For high-risk surgeries, you use the prehab for respiratory, frailty, etc. And in this case, how many days in advance you could prepare the patients to avoid, considering the mood, considering the preparation for the surgery to avoid this process?
Yeah, there's a movement now for prehabilitation, indeed. It's not exactly known what's exactly the best at this moment, but it is about education, about understanding why am I pain, and if I move, what's happening. But movement can also be good, you know. It's about nutrition, and it's about something like ERAS. You know ERAS, the post-surgical technique to reduce pain and to better recover. You know, enhanced recovery of. And that's of surgical series. This was the term. Thank you. So there are many projects I know, and they try to find out what's the best. It also depends maybe on the problem and the type of surgery. It may, for the musculoskeletal system may be different from the abdominal system, and they need other like nutrition, etc. And they also want to prepare people with a better condition, a better nutrition status before surgery, because they are going into an anabolic status after surgery, and you can prevent this. But it's, as far as I know, it's not exactly know what is the best at this moment. Yeah.
Thank you for the lecture, Professor Wolf. I have a question. How do you see in the Netherlands the opioid crisis? Is it increasing there? How often do you see patients with opioid crisis? Opioid crisis.
Thank you. Well, we know the numbers from the United States. And in my country, opioid use in 20 years' time was factor 5 amplified, factor 5. There's now a lot of awareness about this. So we try to learn, all doctors, to know the effects of opioids and only to give them short time. And if pain is longer persisting, first not have the reflex to continue opioids, but try to find out why is there still pain, because then you can target the problem that is maintaining the problem. And so this is about awareness, this is about knowledge. And the main doctors, the main population of doctors that was prescribing opioids in the Netherlands are the family doctors. Then the medical specialists, but first family doctors. And they have not always a lot of time for the patient. Maybe it's also a reflex to, okay, you've pain, more pain, okay, we increased the doses of opioids. But this was factor 5, and now it's quite stabilized with the awareness about this and the program that we are rolling out also in my country. Okay. Other questions?
Congratulations on speak. And I would like to ask you about opioid-induced hyperalgesia. How do you see this? Is it common? How to make a diagnosis at the bedside after surgery? Is it common? Is it a real problem? How do you see all this subject?
we know the dependency after three times giving a prescription, we know that the risk on opioid dependence is rising, is increasing. And in these patients, we see also that there's a pattern that they have more pain and ask for more opioids. And they are in the wrong vicious circle. We see it often, like people with bowel problems, with our colleagues, the medical specialists, visit a lot of endometriosis also, and they use opioids after surgery, and it doesn't help them anymore. And they use like oxycodone, 100, 200, 300 milligrams. And so we asked the patient and we asked the doctor, do you think that it does help? Because if it does help, the patient would not be here. They would not have the pain, would not have that pain. So realize that if they are using opioids and they need more, then probably it doesn't work. Then probably they're becoming tolerant. You can sometimes change, but you should have a nociceptive problem by preference. And if it's not there, there's a big chance that there is nociplastic pain and sensitization. And you can also test because you can, with pinprick, and you can see temporal conditioned pain modulation. Do you know what it is? Conditioned pain modulation is you will give a pain stimulus, and you ask, oh, how much pain does this? Well, I give 8 on the scale from 0 to 10. Then you give at the same time another pain stimulus, and normally it should diminish, it should inhibit the primary pain stimulus. And then inhibition works. But it can be that the inhibition does not work. So this is one of the tests. And another test is repeated pinprick. It's a temporal summation, we call it temporal summation. So each second you give a pinprick at the same strength, and you ask the patient, is your pain, is it changing? And when they are sensitized, they will say, oh no, it's going to be more painful. Then you know there is a type of sensation. And also, it's other parts, more parts of the body. It's widespread. So allodynia also, a normal, you can do the test in these patients. So we often see it, and we have to explain that this is not the right way to the patient and to the colleagues who don't know this phenomenon so well. So we often see this, especially when they're also in the hospital, hospitalized, and still there with a lot of opioids. Okay.
You pointed several risk factors for postoperative pain, and in the real world, some are modifiable and some are not. But from the modifiable ones, do you see some that we should pay more attention and try to change?
Yeah, this is not standardized at this moment. That's why we are experimenting with the transitional services. And so we try first to identify before surgery if there are risk factors like anxiety, depression, opioid use, chronic pain, etc. Because we know that these patients need maybe extra treatment like regional anesthesia, not only systemic analgesics. And maybe also ketamine and pregabalin if there's bone surgery. So we can reduce this, we know that it can help, but I also show that there are a lot of studies going on now to find the biomarkers and to get a better view on what's happening, and maybe that will guide us to better treatment and better prevention. But with some of them you already can use, and you can try to reduce the risk on chronification. Yeah. Okay. Other questions?
First of all, your class were wonderful. I like it a little. I like it a lot. So, what do you think about the regional blockades? For example, S block or PEC block for mastectomy. Do you think that it could reduce the postoperative chronic pain?
As far as you know now in the literature, it can help and reduce pain in the acute phase, but it's still not well demonstrated that it reduces the chronic pain. So for the acute phase it helps, and there's more comfort for the patient, but that's why we have to better identify the biomarkers that are really important. Yeah. If there are no more questions, I really thank you as the audience, and it was my honor to give you this lecture. Thank you very much.
So thank you very much for doing this for us. And obrigada a todos. Obrigado a todo mundo que está online também. E até amanhã. Amanhã temos mais.